So let's start with the theory component of the examination. Now the theory exams are checked either as physical sheets which are there, which come to the examiners, or scanned copies come on the screen which are on the computer screen, and then the examiners sit in a hall and mark them. This happens in the national board, and in that case the answer keys are provided by the national board, and the examiners are supposed to follow that key, and usually you've got long and short answer questions. Now earlier it was a myth, or it was felt that if you have long answers and write pages and pages of that, you would score more marks, but unfortunately that is not true. You should not be wasting time on the length of the answer. It is basically the content which is more important, and I'll just guide you as to how you can do with some examples. And then you've got the short answer types, which have got smaller components to be done, and again you don't have to fill pages and pages of continuation sheets. In fact, I would appreciate not taking any continuation sheet and finishing your exam very precisely and in a more concise manner. So if I was to tell you about the ideal theory questions, I would say that when you get the paper, you have got about 180 minutes, you've got 3 hours. So let's write it here, 180 minutes. And you should use about 10 minutes or so in core planning the way in which you are going to appear in your answer sheet. And so that would involve that either you are doing all the questions in a sequence, like 1, 2, 3, 4 right up to 10, or you are going to change that and do some questions first, 1, 4, 6, 7, which are better known to you, and then come to the rest of them later on. I would strongly recommend that try and do all the questions in a sequence. Examiners find it very difficult to give you marking, and sometimes errors take place because you've got questions done before and after. So if you have to leave a question, you can leave a page vacant. Let's say you have left answer number 3 for later. So you come back to it later and continue with 4 onwards to 10, and then that vacant page you can write at the end of the exam. So how to continue with your long question? So I would say that for a 10-mark long question, about 1 to 3 one-sided pages are enough. So you know, when you write your answer sheet, let me go to the next slide and show you. So this is the answer sheet, and that's the booklet in between. That is a page 1, page 2, and you keep that's the binding of the copy. So I would say that for a long question, 2 sides are good enough. You know, don't waste time in writing too many things. So if this was a long question and I was to ask, the long question is discuss the etiology, pathology, clinical features and management of a 55-year-old female with 5 cross 6 centimeter hard lump in her right breast. Let's make it very simple. Now, so already, you know, there are some cues in this long question. The cues are coming from the question itself: etiology, pathology, clinical features and management. So if I was to see how the marking distribution is made by the examiner, I would say that the marking would have been made that it is 2.5 plus 2.5 plus 2.5 plus 2.5. That is how a 10-mark question for a long question like this would be scored. So when you write your component of these 4 things, you should have it like that. So it's like component A, component B, component C, component D, because they are equal. They are now like four separate short notes of 2.5 marks each. And you cannot take any component lesser than the other. So it's not that if you write too much of etiology, you will score, because you have not given the rest of the three, you will still not get the good marks. So consider yourself tackling the question into this way, and it also makes your task very easy. So here don't start with the definition of CA breast. That's not the purview. You have to start with the etiology. So most likely the etiology, let's say now here is the A component. So etiology, most likely of a hard lump, I would think of carcinoma breast, cancer breast, which is carcinoma. So write a full form, carcinoma, as the most likely cause, which is usually the not otherwise specified type. Or it could be, second would be a malignancy, hard lump, cystosarcoma, phyllodes. And then possibly you would think of other causes, like it could be a large fibroadenoma, but mostly you have to be sticking on CA breast. So then you can go on to the second component and say about pathology. So then you talk about pathology, that amongst the possible causes of CA breast, we have ductal carcinoma, and we have got lobular carcinoma, and then that can be ductal carcinoma in situ and ductal carcinoma invasive, and then similarly lobular carcinoma in situ and lobular carcinoma invasive. So, and then say that ductal carcinoma actually is the most common type, which is more than 80% of our malignancies, and so on. So you can dwell on the pathology for carcinoma breast, because that's your major differential diagnosis. And then you can come to the next component, and that is clinical features. So then is the clinical features, and you can say symptoms and signs. So symptoms of a most important symptom, painless lump, okay, progressively increasing in size and associated with, if the patient has noticed some skin changes or nipple retraction, and the patient finds it also hard, etc., and there may or may not be any lump noticed in the axilla. So which we are talking about the lymph nodes. And the signs. So signs we will talk about signs. So the local signs in the breast, and you could draw a picture here. So you're talking of the right breast. So draw a picture of the right breast. Draw the axillary, the triangle for the axillary lymph nodes, and then talk about the mass here. Let's say this is located in the upper outer quadrant. So that's the irregular lump. So then you can say that it is a lump which has got on inspection. So then you say the inspection findings. So there could be, you would look for peau d'orange, which is the edema because of the blockage of the lymphatics, cutaneous lymphatics by the large malignant cells. So the peau d'orange, and then you would look for satellite skin nodules, and you would look for ulceration. Now those are the three things which are needed for a T4 lesion. hue de orange, satellite skin nodules and ulceration. Nothing else, like for example puckering, dimpling, right, or retraction of the nipple. They do not denote skin involvement. So this should be clear that you want to see that on inspection. Then what do you want to see on palpation? So you will see that the lump, I will look for all these and come back to the palpation in this part. This was signs and this was symptoms, and you're talking about this. So on palpation, you would look for the consistency, that is hard, fixity to the skin overlying, whether you can pinch, or fixity to the underlying pectoralis muscle and fascia. Remember, this fixity and this fixity does not influence skin involvement according to TNM, but this is part of the examination. So you are looking for consistency, fixity. Then when you say that the lump is fixed to the overlying skin, fixed to the underlying structures, that is the muscle, examiners do not like to hear about movement within the lump, within the breast. That is, sometimes you say that the lump is actually moving within the breast. No, that is not appreciated. Either you talk about mobility overlying skin or to the underlying structure. You don't say that it is not fixed to the adjacent breast tissue. That does not, so this should not be used as a description. So consistency, and then you obviously would be confirming the skin changes, and then you come to the axilla, and in the axilla again you would write about inspection of the axilla and palpation of the axilla and all the groups of lymph nodes. That means the anterior group, the posterior group, the medial group, the lateral group and the central group of lymph nodes. And you should know, in clinical examination they will be asked where all these are. And then you would go to the management, so etiology, pathology, clinical features, and lastly the management. And then in the management component you would talk about how you are going to, so the last part of it, which is the D part of it, management, would be investigations and treatment. That is what the management is. So how you will investigate? So you will take the patient for a true cut biopsy. FNAC is not relied these days, but you can make a mention. And so you have to do what is known as the triple assessment. So the first part of the triple assessment is clinical examination, that you have already done in the previous section. Then you would proceed to do biopsy, and you would like to do imaging. So you can say that you will do a mammography. And why do you want to do a mammography in a palpable lump? So you would look for other breast is the most important answer, which is looking for a non-palpable lump in the other side breast and another lesion which is not palpable on the same side. Because when there is a hard lump, basically you must understand that mammography is a diagnostic, it's a screening investigation. It is an investigation which is done in the population, and we do it in high risk populations. Let's say some countries have done it beyond 65, all ladies. Then they brought it down to 55, all ladies. Then some people, only certain age group, but with risk of family history of malignancy, like mothers or sisters or somebody else had a malignancy in that family. Those members would get screening. So this is a screening investigation. So you should be able to define why you are doing a screening investigation when you've got already a palpable lump in the breast. So true cut biopsy, mammography, and the routine investigations which are part of the staging, and then you would come to the treatment component, and in the treatment component you would talk about let us say for this 5 into 6 centimeter size, which is a T3 lesion. So you would now say come to something that on assessment there was no lymph node, and let us say this was M1. So for a situation like this, I would like to do a neoadjuvant. So this is a stage 3 disease, and for stage 3 disease, neoadjuvant chemotherapy followed by surgery and followed by continuation of chemotherapy in the post-operative period plus minus radiotherapy, and describe a bit about each. So this is the way you would like to handle a long question. So I just wanted to make it descriptive to say how this would be done. So in a short note, let's come to the short note quickly. Let us say the short note is, let's change the topic. So a short answer question on nuclear medicine imaging for in kidney disease, let's say. So I'm just trying to make it a little bit more specific. So here you can say that it's mainly of two types. It is DMSA scan or it is a DTPS scan. And whereas you can actually get a separate short note on DTPA itself, and say what is the full form, and so you should be able to say the full form of DMSA, and then tell what is it used to study for. So it is mainly for cortical part. So because this is a agent which will be tagged to technetium 99 in both cases, and it will be concentrated in the cortex. So it will be used to study cortical scarring. So patients with chronic pyelonephritis or small contracted kidneys which need to be assessed, they will be undergoing a DMSA scan. Whereas if there is an obstructive pathology, you would like to give an agent which is excreted by the kidney. So it is taken up by the kidney. The take up is always a function of the blood supply of the kidney. So if the take up is not good, that means the renal artery is not very good. Renal artery stenosis, which patients will get a poor uptake on that side. And then the second component is the DTPA will be secreted. It will not be kept by the cortex. So it will be secreted in the renal tubules, and it will go out in the urine. So it will be used to study the function. So for the functional assessment of the patient, you will do, and that is for PUJ obstruction usually. That is the reason for doing a DTPA scan, and you will see a hold up. So if that is a kidney and that is a PUJ, then a hold up will be seen. And the nuclear medicine imaging, so this is the two type. Now you can use a paragraph at the beginning to tell about the basis of nuclear medicine imaging. That nuclear medicine imaging is a non-invasive way to study the kidney structure and function by using a specific agent which goes into the kidney, and by tagging it with a nuclear agent which is tagged like a technetium 99, which will be able to give the radioactive signal, and when the Giegelmüller counter comes over the body, it will pick up the area from where the radiation is the maximum. So when there is a hold up on this side, there will be lot of tracer here collected in the kidney, and the other kidney, which is normal functioning, would have no tracer by that time. So if you do at 2 hours, then there is still a dark, you will see the dotted lines, and then hardly anything here because it is already passed away. And then at the end in the bladder, you will find that a lot of tracer has come in. Obviously that tracer has come from this side because this side is already, it is not coming. And then the second part is to give diuretic agent like Lasix, and then they say, did this hold up clear with diuretic or not? So if it clears with diuretic, then that means the obstruction is only functional, there is no anatomical blockage. But if it does not clear with diuretic, then that means there is an anatomical obstruction like a PUJ obstruction and would need surgical correction. If it is clearing with lacilactone or with a diuretic therapy, then that means you cannot do much with surgery. That is what is the more important thing. It's a functional obstruction. So there is no need or necessity to actually make another joint, remove that natural joint of PUJ and do another surgery like a Anderson-Hines pyeloplasty, which is a dismembered pyeloplasty. So this is the way you would be doing your questions, and this particular answer can be, I would say, you should try to do in a single page format. So this was the book. You should be able to do it only in one side. That's it. This is your binding book. One side of the paper, that horizontal landscape paper, you should be able to do short note in one and long question maybe 2 pages and maybe a third page because you maybe have more material, because this is usually 2.5 to 3 marks. So 1 page is okay for 3. So 3 pages, 3 threes are 9, would not more than that. So if you stick to this, you will find that your booklet which is given by the universities is sufficient. You would not need a continuation sheet. You don't need to write too much. You need to plan your answer. That's the most important thing. Plan out your answer. So when the examiner is going to mark you and he's there with a red pen, let's say this is the red pen, he'll say, okay, DTPA, this done. He knows about cortical scarring. This is a good mark. So he'll give 2.5 out of 3. That's it. What else do you mark? Most of the things that have been asked. Knows the basis. What is the nuclear medicine imaging? You should write a paragraph about that. A paragraph about the basis, which I told you earlier. That this is a non-invasive method. It can be given even if the kidney function tests are not good. It can still be given. Whereas you cannot do a dye study like a intravenous urography or a CT urography if the kidney functions are not good. But here, even with bad kidney function, can use nuclear medicine imaging. And the other thing is that because this is it is easily repeatable hundreds of times because there is no radiation attached to it. So it's not like X-ray beams, because CT urography or a CECT, they're all radiation hazard to the patient, whereas with the nuclear medicine imaging, there is no such hazard. So you can give it to even babies who have got a let us say a pyeloplasty done for PUJ obstruction in infancy or in childhood, and then you follow it up serially towards the end when they grow up. You can do it very easily. Now let's come to the revised pattern of the DNB exam. So it is usually the practical exam now, having talked about the theory exam. It's done in a day, and you've got component of OSCE, which has got 20 stations usually. You have to see how many marks it is. This is just a rough kind of a guidance that I'm telling you. And then you've got 100 marks coming from this and 200 marks coming from the actual practical case, which is cases and the viva together. So if you have got let's say about 10 marks each from the 4 vivas that we were talking about, then you are left with 160 marks, and then 160 marks will be divided amongst the cases. So you could have 80 marks for the long case and 20 into 4 for the other bit. No, it's not like that. There will be a ward round as well. So let's correct it. This was just a conjecture. So this will be divided into long case, short case, and ward rounds. These 160 marks, and this will be usually 40 marks. Let's say 10 into 4 stations, 40 marks, and then 120 marks. This will be 60 for the long case, and 20, 20, and 20 for the 3 short cases. So this is the way I'm just giving you an idea about how the 200 marks will be distributed. There is a set distribution which comes from the board. I'm just trying to tell you so that you have a plan in action, that what is the important place. Obviously then this component of the long case becomes very important. It is 60 marks. You got to do it very well. Also your 3 short cases become very important, because there is a external, there are 2 examiners here in this group for you, and there are 2 examiners in this group for you. Usually it's a pair of examination. So you need to convince the examiners that you know the art of case presentation, and I'll be talking about the various ways in which we are talking about managing coming with the exam. So exam schedule comes to you. You got reporting in the morning, then you brief, then you go to a virtual OSCE. Now this is the virtual OSCE. We started from the national board during the COVID times, and I had the opportunity to actually start the OSCE for the first time, because the challenge came as to how to conduct the exam when there are no patients. The whole country was closed, but you had DNB candidates waiting to be examined. So because of my experience in organizing the Royal College of Surgeons OSCE examinations for very many years, and with the guidance of the ENT component, which had already been doing OSCE in their practical exam, we combined that knowledge to create the OSCE, and this, I'm very happy to say, is still continuing, and it's very good because it is the objective way of finding difference between one and the other. There is no interface which can be biased because of your look, because of your presentation, because of your language, because of any other thing. There is no bias. This is absolutely a clean slate on which you can be evaluated. So you should feel very confident that this will be a very neutral way of finding out how much you know or how much you don't know. And then the practical exam runs from 11 to about end of the day. So in the OSCE component, now let's come to the OSCE bit a little bit. The candidates are seated in a hall, and you have got answer sheets which are given to you. So this is the way the answer sheet works. Let me blow it up for you like that. I'm magnifying it. So this particular one was a scanned one from it gives the national board thing, and you have to write your roll number, station number, signature, invigilator. So you have to write, and at the end is the below is the examiner who is checking. So this is it's a white sheet. It is, you have to write. There is nothing printed on it. So the question comes on the screen. That is the OSCE question, and you have to write the answer on the screen. Now conventionally, the way the OSCEs were designed was that there are stations, and the candidates get inside the station. Either there is a teacher or an examiner there who takes your exam, or there is just a structured instruction, and you do the instruction and you move outside the station. So the candidate actually moves from one station to the other. Here the candidate is seated in the hall along with all the others, and the stations are moving in front of them one after the other. But the principle of OSCE remains the same. That is, the time of entry and time of the exit is limited. Once you get into the OSCE station, your time starts, and once you get out of the OSCE station, your time finishes. So basically, you have only that much time, and when you go to the next station, you cannot come back to that station from where you have come out, because that time is gone. The same principle is being used here. So even if you recollect an answer of your previous question or previous station that came from the OSCE, you cannot answer it, and I will tell you how it is done. So the time allotted for the questions will be displayed on the screen. questions of a station may be a single slide or more than one slide. So basically the OSCE is coming to you in the form of a slide, a PowerPoint slide, and the questions once completed will not be repeated. So that is the way you are saying that the station is gone, and the answer sheet that is filled up by you will also be taken away by the invigilators after every station. So there is a 15-second gap between each OSCE question, and in that 15 seconds you are supposed to put the other sheet on the left hand side or right hand side, keep it away, and get ready for your next. The bunch of 20 answer sheets for 20 stations is already given to you. You pre-fill your name, everything already on that. So you don't have to do, only the vacant part is you have to write the station number and start going. So the answer sheets will be collected after each station is completed, and these answer sheets will be checked that the invigilator has signed, everything is complete, so that you are okay with it. So now let's talk about a little bit of a non-surgical OSCE stations. Now this particular one you can see talks about patient coming to the emergency department with palpitations for 30 minutes. His blood pressure is hypotensive. So the patient has had a cardiac event, and there is ST elevation. You can see there is a ST elevation MI. It's a STEMI. So it can be a STEMI or a non-STEMI. You have to see that. So you have to say what is your diagnosis. You have to write it down. Station number 1A, this is the one of the two. So this is 2 minutes only, and this timer will also start. So backwards. So it starts moving backwards. So you come to know here. I'm trying to show you on the screen here. Here the timer will start doing reverse counting. This counts. And this tells you that this is only one of the two. So only half page has to be written. This is question number 1, 2, 3. So that means 4, 5, 6 are also going to come. What is the first step in the management of the patient in the ED? What will you do? So you have to tell that. You will provide oxygen. Oxygen is the airway. You must provide oxygen to any patient, especially whatever it is, because A, B, C, D, E, that protocol has to be followed. Because why A? Because the airway kills before the breathing, and the breathing kills before circulation. So common thing is you will start him with a drip or something. That's not the answer. You have to start with oxygen. Whatever is there, give him, optimize his oxygen, and then you will start doing other things. And what is the complication of the the particular management itself, and name the management. So this is a medical question. Relevant answer can be given. Now part 2. That means the second part of the same station. This is a slide being shown for the same station, same sheet. The sheet does not go away. 4, 5, 6. That means you have to continue in the same sheet. Same sheet of the station number 1. Because this is 2 of 2. And this is also 2 marks. So that 2 minutes. So this was a 4-minute situation. Depends. Whoever is conducting, they will tell you how much time is there for each station. So what are the findings? You have to tell about the finding, that there is a effusion, there is a pneumothorax, and see if there is any fracture ribs. So whatever 4 findings you can see, there is a shifting of the trachea to the opposite side. Okay, like that. Whatever you can make out, you have to give, and there is a collapse. So these are the 4 things that can be seen. There is a collapse, there is pneumo, there is a effusion, and there is a shift of the mediastinum to the opposite side. And what are the differential diagnoses based on this? So these were some of the examples which can be not related directly to surgery, but just for your understanding how this works. So again, you have a sheet. Now in this particular case, there is a single slide. So this 4-minute slide is going to be, this time will run backwards, and this is only one example of a slide which has got only one PPT per OSCE station. So you will have to answer these 4 questions on the same sheet. So for example, in this particular case, this is a history of a patient who is a 55-year-old man who is brought with the history of acute left hemiparesis of 12 hours duration. So there is a stroke, and you have to identify the area which is involved. What is the finding and diagnosis on this brain computerized tomography? Is he a good candidate for intravenous thrombolysis? What surgical procedure may be required in this patient, and what medication may be required to prevent recurrence? You have to answer these 4 questions one by one in that particular sheet.